My name is Adelola Adeloya, Professor of Neurological Surgery, University of Ibadan, Nigeria, and Chief Consultant to the Teaching Hospital, University College Hospital in Ibadan.
My name is Yorvan Kiryabwire, Consultant Neurosurgeon, Mulago Hospital, and Head of the Department of Neurological Surgery.
It is my pleasure to be talking to you today, Professor Kiryabwire, about neurosurgery in Uganda. But before we get going, can you kindly tell us something about your background?
Oh, that's an interesting question. You know, I started off in the humble way, and I come from the eastern part of Uganda, and I went one of the simple schools, sub-grade schools. That's where I started, and then later on worked up to go to a fairly good secondary school, missionary school, which was in Amali High School, at the footsteps of Mount Elgon. Following that, I passed to get to Makerere College, as it was called then, which later on developed into Makerere University. And of course, I took the science courses, and later on, I was admitted to the medical school.
Did you have any particular reasons why you went into medicine?
Well, that's also an interesting question, because as a young man, I think I wanted to try something difficult. That's one exciting thing probably which took me to medicine. And secondly, that there were very few doctors in my area. And it was, of course, probably still today, that it was somebody who is good who could probably get into the medical school. And when I got into the sciences at Makerere, I applied to get to the medical school, and I passed and got into the medical school.
Congratulations.
Thank you.
Now, you did surgery, not medicine. You could have done medicine, you could have done other specialties. Why did you go into surgery?
I did surgery. That appeared to be more practical. And I didn't feel, when I qualified as a doctor, I didn't feel that it was enough for me just to treat patients with medical treatment. I thought that I would make a diagnosis, proceed to operate on the patient, and I thought by doing that I would achieve more rather than prescribing medicines and so on. It wasn't much, I wouldn't have got much satisfaction from it.
Thank you very much. Then you ultimately trained in neurosurgery. Would you like to tell us why and where you went to neurosurgery?
You know, you remember our time in Dublin, and as we were doing our primary fellowship, I think that's where everything started. And I still vividly remember, you know, when we were revising and we were about to sit the exam, we said we will meet at the pituitary. This is a very, very funny thing, because in the end, actually, before we come there, we separated after having passed that exam. And then we proceeded to do the fellowship, the final fellowship, and I became a general surgeon. Went back to Uganda and practiced as a general surgeon. I went back to Uganda in 1964, worked as a general surgeon, and became a senior lecturer. And then there was a lot of development taking place in in Mulago, Kampala, at the hospital. And they were starting to get specialized units started in the hospital. And they started with orthopedics. I didn't like very much to do orthopedics because I thought that was not really very much scientific. And cardiothoracic surgery and neurosurgery. And I picked on neurosurgery because I thought it was very challenging. And in fact, many people were avoiding it. And I thought there would be no reason why I shouldn't join neurosurgery. And so I got into the neurosurgical unit. Mr. Ian Bay came from Belfast and started the unit under the supervision of Professor Locke of the Nervous Hospital, National Nervous Hospital, Queen Square. He visited Mulago in 1968, and we worked with him for a week. And in fact, he offered to take me to his unit at Queen Square to train in neurosurgery. And I think the stage was set, and in 1969, I went to the National Hospital, Queen Square, under Professor Locke. I think you had just left the place, is that not so?
Yes, yes. It is a very interesting thing that in spite of the large size of Africa, at least neurosurgically speaking, it's a small world. And here I'm talking to you now. We prepared for the fellowship together, and we decided we'll meet in the pituitary, which we did, and we both became neurosurgeons. And one of our colleagues in Kenya, Dr. Sandy, also passed through an institution where I met Ian Bailey. And Ian Bailey ultimately came to Uganda to start neurosurgery. And our meeting point again is at the Queen Square under Professor Valentine Logue. So there has been a type of uniformity in our experiences during training for neurosurgery in Africa here. Would you like to tell us the pattern of neurosurgical diseases that you now deal with in your practice in Uganda?
The commonest problem in my practice is trauma, and I deal with head injury trauma. And recently, of course, we have had a lot of civil wars in my place, in our country, and missile head injuries have been very common. And these have taken up most of my time. On the cold aspect of neurosurgery, the gliomas as tumors of the brain are very rare in the Africa, and I think this is your experience too.
Correct.
But I think the component of meningiomas, pituitary tumors, these are very common. Fortunately, these are tumors which are rewarding in any way. I don't think one should lament over the rareness of the gliomas. And then I have a special interest in spinal surgery.
Yes.
And of course, the commonest lesions there is meningiomas and neurofibromas. These take up the usual pattern. I don't think there's a difference between the European practice and the African practice. And of course, we see a little more infections, intracranial infections, than in the European practice. And of course, we get congenital malformations. I've seen a number of craniopharyngiomas,
yes.
Fairly a number, probably a little more than one would have anticipated. And the other thing which I should mention really is that for the posterior fossa tumors, acoustic neuromas are rare. Unfortunately, medulloblastoma tumors are rare. Yes. Of course, you have the congenital lesions, which is the hydrocephalus and the meningomyositis.
Yes. The spectrum of diseases you see in Uganda is broadly similar to what we've seen in other parts of Africa. The rarity of the glioblastoma multiforme, the rarity of the acoustic neuroma, and the common occurrence of meningiomas. What are your experiences with the management of hydrocephalus?
Oh yes, this is a very interesting question actually. You know, we don't have the valves, and they're very, very difficult to come by. So my interest in doing hydrocephalus, I usually do air encephalogram on the hydrocephalus to establish whether this is a communicating or non-communicating hydrocephalus. And this, in fact, influences my practice. And if the hydrocephalus is communicating, I usually do a lumboperitoneal shunt.
Lumboperitoneal?
Yes, and this works if it is placed properly. It does work as well as the other methods, other types of shunt which need a valve. And this cuts down my expenses.
Yes.
And in fact, it is a very good method of managing hydrocephalus.
Yes.
But of course, if the valve is available, in fact, I don't like doing the ventricular-atrial shunts. I like to do the simple ventricular-peritoneal shunt. It is easy. You don't need complicated anesthesia, and you don't need screening during the operation. So straightforward. And if any problem occurs, it is very easy to revise.
I'm happy that you mentioned your special interest in spinal surgery. Are there any ways in which the pattern of diseases you see in the spinal axis differs from what you saw at the Queen Square, for instance?
I think the other main thing is that our population is young. And so the patients appearing with the spinal tumors are also relatively young, the vast majority. But you know, with the meningiomas, spinal meningiomas, it is classic, common in the women, in the dorsal spine, and for the neurofibromas, again, you get the stigmata of neurofibromatosis. Yes. This is actually, I think, classic. Yes. I don't think there is much difference.
Now, you have only one center of neurosurgery in Uganda. What are you doing about the development or the expansion of neurosurgical services in Uganda?
I think my next move for the next neurosurgical center will be in Mbarara. You remember we have started a medical school in Mbarara, that's southwest of Uganda. And naturally, I think the next neurosurgical unit will be in Mbarara. And the other one will be in the north, very far from Kampala, Siguru. At the moment, we have just established peace in that area. There's been war going on. And as things settle down, we will need to improve the facilities in order to be able to start a neurosurgical unit.
So you will have a geographical distribution, one in the north, one in the south, and with Kampala
in
where
center.
It is in the center. Yes. Right now.
Yes.
Yes. That is the geographical problem. What about personnel? How are you going to man these other centers?
I am actively trying to train young people to come into the neurosurgical unit. And as you know, I have Mr. Kawa, who is already fully trained neurosurgeon. And I sent out Mr. Volo, who went to Glasgow. Unfortunately, that one didn't come back. But we are speaking here in Harare, and I've got Mr. Dafara, who has come to train, and Professor Leve.
Yes.
And I think in 2 years, he will be able to come back. And already I've got another registrar, a chap who was at is a mate, who has joined me in the department.
Yes.
So this is, I think the stage is set for the personnel.
Very good. So just like other parts of Africa, what you are doing is combining local training with overseas training, or a mixture of both. You did mention a few minutes ago the question of somebody going and not coming back. We have this similar experience in parts of Africa, particularly in my country, Nigeria, where nationals will go and train and won't come back. Is there any, why do you think that is happening in Uganda?
Basically, I think this is an economic problem. And as our economies are aiding, then they get brain drain.
Yes.
But I'm sure it should not deter us from continuing to train.
Correct.
Because one hopefully feels that these people will return. And the other point is that we should try to influence the administrators at home to improve the conditions of the professionals. You know, it takes some time for somebody to become a neurosurgeon. And I think as he starts work, he should be rewarded financially. So if we don't do that, then I'm afraid we will continue to suffer the brain drain.
Yes, we have a similar experience, and the reason we give for the occurrence of this in Nigeria also is economic. Now, what about research? I know it's a difficult question if you are alone and you are heavily loaded, but still you may have some interest in research activities. Do you want to make some comments about this?
I have interest in research, and mainly, in fact, clinical research. So basic research you can't manage because of lack of facilities, and in fact, being one person, it's very heavy clinical load. And my interest has been in studying pituitary tumors, clinical aspects of pituitary tumors, and the incidence, the frequency, and so on. Yes. And you know, talking about pituitary tumors, is that of course, the chromophobe is the very common ones. This is a very, very common tumor. And I don't want, when I do excision of the pituitary tumor, I don't completely remove the tumor. Obviously, I'm not doing it under a microscope. And later on, I wean my patient off the steroids. This is very fundamental, because sometimes in the country there may be no steroids. The steroids may be out of stock. And it is important that you don't keep patients chronically on steroids. And in my practice, this is what, in fact, I do.
Yes. Do you have any endocrinological backup? Do you have any physicians to assist you in the...
Yes, we had this.
Working up these patients.
You know, and we ran out of the isotopes. And recently, again, we have rehabilitated the unit, but we haven't received the isotopes yet. So, hormonal assay. But this, I don't think it would stop somebody doing a lot of pituitary work.
Yes.
And
is there any particular message, apart from the fact that you are telling us to be cautious about the use of steroids in them? Are there any other aspects of the pituitary pathology that you like to share with your colleagues in Africa who also deal with very large pituitary tumors?
What I would tell them is that I don't think there is it would be necessary, one working in Africa, to do hydrocephalus and following it up with radiotherapy, because that is a sure way really of ablating the tumor, ablating the pituitary completely.
Yes.
And there, after you have done that, you are in fact committed to steroid replacement.
Yes. Okay. In your department, you have you've had a senior lecturer, you've had some trainees. Are there any published materials or any aspects of neurosurgery in which you have taken special interest, which you like to share with us?
Well, besides that, at the moment, we are studying the effects of HIV into central nervous system.
Okay.
And it is becoming, as the disease is spreading, it is becoming a very heavy burden to us, because about 20% of the patients, the clinical picture of HIV is changing. It is not the classic WHO definition of fever, diarrhea, and loss of weight. A very healthy person can be struck with a paraplegia without any other prodromal symptoms. And these patients are coming to us.
They come to you in the neurosurgical
yes,
department.
as the first presentation. And we are getting many of these. And of course, the increased intracranial pressure and tumors which are appearing now, and cranial nerve lesions, all these present. And I am surveying these, trying to assemble them to see what sort of picture it is.
I think it is unique opportunity probably gives you a chance to be able to look more closely into this. The Kaposi sarcoma, I know, is common in your part of our continent, and HIV has been linked with Kaposi sarcoma. Has this disease presented to you as a neurosurgeon?
There is the florid type of Kaposi sarcoma, which is in fact HIV related. The classic Kaposi sarcoma still presents itself.
Yes.
But this florid, very rapidly growing tumors, now in fact very common, and they get metastases to the brain. So this is one aspect which is in fact keeping us very busy.
Now, tell me about training generally. Now, you said you sent some surgeons to England. Are there any further thoughts about training?
I think that training should be, they start in my unit. They work with me for a couple of years. When I get somebody after he has done his Master of Surgery, that's which is, of course, it's equivalent to the European Fellowship.
Yes.
And I take them through practical work, clinical work, and train them to send them into radiology to do some air work and carotid angiography. And then I feel strong, and I think this is the general feeling in the Association of Surgeons of East Africa, that the training should be local. We should train in our region. And that's why, in fact, Mr. Dafara, I've told you already, that he's here in Harare, training under Professor David. And I think this is what we should do. First, it is less expensive. Secondly, in fact, they learn the relevant things, because the spectrum of disease, as we have discussed, is the same in Africa.
Yes.
And the other aspect of it, that probably is unlikely. to jump to get away without, he's likely to return to the country.
So they are less likely to be lost to you.
Yes.
They train locally.
Yeah.
And finally, what practice of neurosurgery in Uganda, has it been hampered at all by the lack of sophisticated neuroimaging equipments?
You know, you can do a lot to assist people without all these sophisticated investigative facilities.
Correct.
And in the unit, we have facilities for doing air studies. You can do myrograms and carotid angiography. And this is, of course, the basic investigations. We haven't got a CT scan in Uganda yet. Obviously, it means a lot of hard work and clinical achievement to make a diagnosis without these sophisticated facilities. But I think this is the basic thing we have had. The other one is, of course, the problem of our destroyed economy, that we sometimes lack what would be fundamental basic facility.
Yes.
And this is what is irritating in most cases.
Yes.
You know, if you are unable to get either gloves or to get something which you really need quickly, you know, say drugs as well. This is what is really more serious than the modern facilities.
Yes. You've told us about your plans to establish centers outside Kampala in the north and in the south. What do you see as the future of neurosurgery, firstly in your country, Uganda, and secondly in Africa as a whole?
I think the future is bright. It would be very encouraging indeed. You know, neurosurgery, I think, is established on the continent at any rate. That is firmly done. And I think the next step is expansion. It will depend on the economies, if the money is available, and for training the personnel and establishing the units. But as you know, this neurosurgery at the moment is firmly set on the ground. Because I think when we started, it was shaky, yes.
Yes. I agree with you. It is an established discipline now. What we need is to consolidate, and on this consolidation, the future can be built. Yeah. Any messages for young neurosurgeons coming after us?
Yes, I would invite them to join us. I know many doctors feel this is a very difficult discipline, and it takes long to qualify. But I'm sure for the young man, it is the challenge to him, because neurosurgery is very exciting. I think you have enjoyed yourself, I hope.
I have.
And I'm sure the young man who joins neurosurgery should not be disappointed. There is a lot of interesting aspects of our work, and you need discipline. You need to know your anatomy, and then you need to know the technique. Is actually very interesting. So a young man who wants to do something challenging should join us. It's a very interesting work.
Thank you very much, Mr. Kiryabwire.